Hi guys, I'm Dr. Donald Pelto. I'm a full-time podiatrist in Worcester, Massachusetts. Welcome to Podiatry Practice Mastery, where I help other podiatrists develop successful principles and skills in their private practice. I hope you find these videos simple and insightful, and I'd love to hear back from you. Okay, so please comment underneath these videos. Please subscribe to the page.
Hey, Don here. Welcome to the weekly update for Podiatry Practice Mastery. This is part 2, where we're talking about the 8 high profit procedures to skyrocket your revenue. Last time we talked about using EPAT, using ultrasound, and then using amnio, kind of how they go together. Today, we're going to start with high profit procedure number 4. These are going to be nail procedures. So once again, just to repeat, the best thing in terms of practice is to do procedures. That is the most beneficial thing, because usually you're doing a office visit and then you're doing a procedure code at the same time. And these are simple procedures that we do in the office for nails. So this might be obvious for some, but I'm just going to kind of go down and explain it because there might be some new practitioners to make it a little bit easier. We're going to talk about nail avulsions, I&D or incision and drainage, and then we're going to talk about different types of matrixectomy procedures, and then high profit procedure 5, we're going to talk about some of the cosmetic things that we do, or not purely cosmetic, but Cariflex and Onifix. So let's first talk about avulsions. So there's a couple of types of avulsions. I'm going to talk about some of my mistakes. My biggest mistake is when I do a total nail avulsion. The gauze can sometimes stick. So I always tell patients that the gauze might stick. And a lot of times, if I want to be nice, I will put some Adaptic, a little square of Adaptic on top, and then whatever you're using. We use a Amerigel, the red stuff, and then gauze, and then we do this taping sequence. I do my neat little smiley face every time. When I finish it, I have a black Sharpie in my pocket, and I always put a smiley face upside down on their bandage, just as kind of a fun thing that I do. So that is the avulsion. Now, one thing that I didn't always do, there are total nail avulsions. And when would I use that? Well, anyone else, if they have a nail that's already falling off, if they have a nail fungus that I'm just wanting to pull off the whole nail, I just remove one nail. I don't usually remove multiple nails. And I don't use avulsion as a standard for nail fungus. Occasionally, I'll do it for a single nail. So about nail avulsions, a lot of times I'll take that and I'll send it for pathology. If I'm doing it as well for a nail sample, I will just send that whole thing and I will avulse the nail. In conjunction with a nail avulsion, sometimes I'll do a partial nail avulsion, which would be just the side of the nail. So when would we do that? And why is that not an I&D? So I consider an I&D if there's swelling, if there's redness, if there's signs of infection, if there's pus, that is considered an I&D. So a partial nail avulsion taken out the side. But if there is only callus in the edge and there's nothing else really going on, but there's an ingrown toenail, I will call that a nail avulsion code, and I'll do a partial nail avulsion code. So I have both of those templates that I have. So total nail avulsion, partial nail avulsion. If it's not infected, then I call it a nail avulsion. When the nail grows back, a lot of times the nail, as it's growing, it can hit the tip of the toe where there's bulbous changes. And so because of that, I'll let my patients know sometimes they have to do T-taping at the tip. So they'll do it like a taping at the tip, and I have some videos that kind of explain that. So that is nail avulsions 101. I usually see them back at either don't see them back if it's something real simple, or I'll see them back at like 2 to 4 weeks, depending, for nail avulsion. So usually this is done in conjunction with anesthesia. So I'm numbing it up. Usually you do it in conjunction with anesthesia. And that's the way you can bill it. So it bills with anesthesia. If they have neuropathy or they don't need it, I would document that. Like if it's really loose or something else like that, I'll just document that, and I don't always have to anesthetize the toe. So that's a nail avulsion. That's my favorite procedure. There is also a nail procedure that's an I&D, which everyone knows. If there's an infection, I will do either a partial I&D of just the edge. That's most common. If there's an ingrown toenail, otherwise I can avulse the whole thing. If there's an infection, I will call it an I&D. If it's an infection, it's an I&D. If it is So even there's pus in there, even though I'm avulsing it, I'm still calling it an IND. And the reason for that is the IND tends to reimburse better than the avulsion code. So that's kind of the way we would do that. That's the IND. A lot of times for incision and drainage, I will do that for like an ingrown toenail or other types of INDs. We're talking about nails mostly. If it recurrence, then we'll do a matrixectomy. Usually if there's signs of infection, I tend not to do a matrixectomy that time. I'll have them come back in 2 weeks or after, and then I will do the matrixectomy. And the reason I explain that is I don't want to seed in a bone infection. I've never had that happen, but I just get a little paranoid and I don't want to cause that. Usually for INDs, I tend not to give an antibiotic. Now, we're talking about billing. Occasionally, I guess if you did an antibiotic, you could bump up the code, I guess. That would be a reason to do that. But I tend not to do an antibiotic for patients that have, unless it looks really bad. So that's INDs. It can be partial, it can be total. There's an IND code. Once again, if you want all these codes or these procedures templates, you can get them all at podiatrypracticemastery.com/EMR, capital EMR. And then the last one would be a matrixectomy. A matrixectomy is where I take out the edge or the total toenail. Once again, with matrixectomy, I usually use a post-op kit. My staff goes over that kit. They have them sign something that they can get that kit, and they use that after. There's also an option for soaking. So that's the procedure that we do to make the nail not come back. I always tell them there's going to be redness, there's going to be swelling, there's going to be drainage, but there could be recurrence of it. That's the most common complication is recurrence. Occasionally there can be infection, but normally it's not an infection. It's usually just from the chemical. We use sodium hydroxide. I put it in there for 30 seconds and then I flush it with vinegar to neutralize it. That's what we do in our office. We used to use phenol, but the phenol expired a little bit sooner, so we tend not to do phenol. So that's what we do. So that's the high profit procedures. Those are all the nail procedures that we do that are involved. I guess the other nail procedure I didn't go over was we'd be doing a biopsy. So let's talk a little bit about that. If there is a line in the toenail or something you're concerned of, like a melanonuclea, we can do that. The way I do that, there's two options. One is you can cut through halfway through the nail and flip it back, and you can biopsy if it's underneath the nail bed. If it's at the nail matrix, you can cut incision at the base here on both sides and flip that area of skin back, and then you can do a biopsy, either like a tangential, which is a shave biopsy, or you can do like a punch biopsy. If you're going to do a punch, I tend to do a 3 millimeter punch right through the nail and into the nail bed. If we're concerned about something, that usually grows just fine. Same with the tangential. That's a little beyond this, but that's another procedure that you can do on the nails if you're concerned about anything like that. So that's the high profit procedure. Number 4 would be the nail procedures, and then number 5 would be Cariflex and Onifix. So let me talk about both of those. First, Onifix. So Onifix is used for ingrown toenail if there's not an infection and if it's just kind of digging in. The main key is that when you look at an Onifix nail, it has to be flat at the back and then curved at the front. That way it can bring this flatness and lift it out slowly. That's how the Onifix works. It's real quick to do. It takes like 3 minutes. In our office, we do it. I think we charge $125 per nail that I'm doing it for. So it's a real quick thing. I usually have patients come back every 3 months and I assess them, and I'll usually put a second band on proximally. And over time, it can help people's ingrown toenails. I still tend to do more nail procedures than I do Onifix, but for some patients that don't want to do anything, I will do it. I tend not to do it if there is infection in there. But if there's just pain or buildup of callus, I can do it. So we were talking here about Onifix, and that's kind of how I use it. I use it for ingrown toenails, toenails that are painful, and I put on the strip. I sometimes might do the strip every 3 months until it grows out. And I don't do a ton of the Onifix. Another good reason for the Onifix would be if you are letting it grow out after an avulsion, and the nail looks a little bit dystrophic. So you are able to help it with that. So that's kind of another way of doing it. Okay. I'm blurring my background because I don't want you to see the computer behind me. So the other thing is doing Cariflex. Now, this is one of my favorite procedures. And I do this for ugly toenails. So I do it for ugly fungal toenails, nails that are typically shortened due to a disappearing nail bed, due to a nail that's kind of growing back. And so you can put this Cariflex. It takes practice putting it on. My first ones were horrendous and they did not look good at all. The new ones I do now look pretty good. Some of the mistakes I've made are not making them thick enough, so they fall off, making them too thick, so they look ugly. So I tend to first grind down the nail a little bit. This is the only thing I grind for. We do not use grinders in our office. The only thing I use is for that and for Honeyfix, where I grind it to buff up the nail. I put on the thing to kind of clean it off. I put on a portion of the Cariflex, use the UV light for 30 seconds, do the rest of it, UV light for 2 minutes, file it down. That's the reason no one else in the office likes to do this, or actually some of my colleagues don't like to do it because they feel like they're a nail technician. I use that little wood stick thing. You kind of feel like a nail technician, kind of making it, but it makes it look good. And you use the little you kind of file it down. And then after that's done, I put on the sealant and I do it for another 2 minutes. So it takes some practice doing the Cariflex, but it's like the only procedure that my patients really cry about because they're so happy. So I would recommend doing it. I think patients like it, makes them feel better, makes them feel more confident. We charge $75 for the kit if they need the kit. And then usually the kit is good for like 2 visits. And then I think it's $125 for the first nail, and then like $25 for the second nail. I think it's underpriced. I think we should charge more for it because it's a lot of work for me to do. Even though I know there's 2 nails, it's work having to do it to make it look good. Because usually sometimes you have to do it a couple of times, and sometimes it gets softened, and it just takes practice. But once it's done, patients are pretty pleased with it. So those are the kind of the high profit procedures when we're talking about toenails, different procedures, avulsions, matrixectomies, INDs, and then Cariflex and Oniflix. So those are the main things that we do that for profit. I guess the other thing I didn't include in here, I guess I can add right now, it would be lunula laser. I didn't really include it initially, but as I'm thinking about it, it's a procedure that we do in the office. I use Lunula. We used to have the backstory here is we used to use Cutera. So we have a Cutera laser, and I use that on warts, and I think it works well. We have a Remy laser, and we have a Lunula. And I don't know if any of these people are listening. I hope not, but I find the Cutera didn't work all that well, and I felt bad telling people it didn't work. The Remy I haven't tried, frankly, and the Lunula I like it because they put their foot in it and they can have the treatment. Whether it works or not, I think is a different story. I tend to talk more patients out of the Lunula than I do into them. But if they do it, like if they don't want to do the oral medication, and if they want to try this first, I have them get 4 sessions of Lunula a week apart, and then I have them do a 3-month follow-up. And then at 3 months, if it's not looking better, or like we're not seeing some proximal clearing, then I'll put them on the Lamisil. So for patients that do that, I don't do a lot of Lunula. We charge $150 per foot. So it would be $300 total per session, so about $1,200. But the nice thing is the staff can do it. I don't think any of them work great, but if some patients really don't want to do the oral or they want to try this before the oral, that's what I'll do. So that would be another type of a patient. So I'm going to stop with these 2 high profit procedures. Next time, we're going to talk about procedures for warts. And I still have left a couple of other high profit procedures. So we'll talk about that next week. Okay. Once again, if you guys enjoy this, please join Podiatry Practice Mastery. Go to the YouTube. You can join my YouTube channel there as well. Okay. I have a great offer for you guys underneath here if you want to join Practice Mastery. Thanks.